Good evening, dear students. Today is the 4th February 2026 evening, and we are starting with our first session of free demo class, Fast Track, NEET, Super Specialty, and MD courses that Pediatric Made Easy by Dr. Dilip Kumar Bhagwani, former senior pediatrician at Hindurao Hospital. So this is our course profile. Whosoever may be interested and like the session may subscribe it, share it, and comment in your comment box. Your comments are very valuable to me. And let's start with the disease, celiac disease. In my times, the celiac disease used to be unidentifiable disease because of the lack of awareness and the test during the era of 88 and 90 times. And then the awareness began and it spreaded, and people starting diagnosis children with celiac disease. I have taken the references from gastroenterology clinics of North America, Aspagan 2020-24 guidelines, Nelson textbook of pediatrics, 22nd edition. During World War II, celiac children improved during the food shortage when the bread was unavailable. After the war, symptoms recurred when the bread and cereals were reintroduced. Dutch pediatricians William K. Dickey recognized and confirmed the association between the cereal gains and malabsorption. Regarding the pathology, the preliminary pathology was celiac disease is an immune disorder that is triggered by environmental gluten in the generally predisposed individuals, also known as celiac sprue, non-tropical sprue, gluten intolerance, gluten sensitive enteropathy. The grain protein exists in 4 general storage forms which are categorized by their solubility characteristics as prolamins soluble in ethanol, glutenins soluble in dilute acids or alkali solutions, globulins soluble in 10% normal saline, minor albumin soluble in water. Glutens specifically are the prolamins and the glutenins. This can be important MCQ. Coming to the pathogenesis of celiac disease, as you see in this slide, there are enterocyte linings, enterocyte cells, and there is a gluten antigen. The proposed pathogen of celiac disease, gluten is absorbed by the small intestine mucosa in the lamina propria and presenting in conjunction with HLA-DQ or DQ cell surface antigen by antigen presenting cells, probably dendritic cells. To sensitize T lymphocytes that express the alpha or beta T receptor efferent limbs, tissue transglutaminase, deamidase, gliadin peptides, gaining acidic negative charge glutamic acid residue from neural glutamines, because negative charge residues are preferred in positive 4, 6 and 7 antigen binding grooves of HLA-DQ2. Deamidated gliadin elicits storage T lymphocyte response. This T lymphocyte then activate other lymphocyte to generate immune products, cytokines that damage the enterocyte, resulting in villous atrophy. Induction of the HLA class 2 surface antigen on the enterocytes can permit additional gluten antigen presentation by these cells to the sensitized lymphocytes, and anti-glutamase antibody, anti-gliadin antibody, gamma interferon, interleukin 2, 4 and natural killer cell are activated. Ultimately, they destroy the lumen, the mucosa of the small intestine, and there is a villous atrophy and infiltration of the lymphocytes in the lamina propria. This is just a brief overview of the previous slides. The another important component is when the wheat antigen attached to the surface of enterocytes, the enterocyte get damaged and duodenum of the epithelial barrier ruptures. It produces fatty acid beta protein, which is the responsible for all the symptoms of celiac disease. Coming to the spectrum of celiac disease, the spectrum can be symptomatic, silent, latent and potential. The symptomatic being the most commonest, 60 to 70%. The silent as the first degree pedigree of the celiac disease are silent celiac disease. The potentials are the subject with positive celiac disease serology but without evidence of altered intestinal histopathology. Patient may or may not have symptoms and signs of disease and may or not develop a gluten dependent entropy later also. This potential group comprise almost 15 to 20%, and the silent comprise around 1 to 5%, and 1 to 5% are latent. 75% of the symptomatic patient have a frank malabsorption symptoms and signs like chronic diarrhea, failure to thrive, weight loss. The extra intense symptoms last like anemia, fatigue, hypertransaminemia, neurological disorder, short stature, dental enamel defect, arthralgia, and aphthous stomatitis. In the silent, there are no apparent symptoms in spite of historic evidence of villus atrophy. In most cases identified by serology skating at high risk group, as I told you in the first degree relative of the celiac disease patients. The latents are the subject who have a normal intestinal histology but at some other time have shown a gluten dependent enteropathy. Subject with this potential we have already discussed. Coming to the clinical and demographic comparison of celiac disease diagnosed during adulthood versus childhood. This is very important. In our mind, we always think that the celiac disease is the disease of childhood. No, 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 no. There is a spectrum of disease from 1 year to 80 years. The patient may manifest the symptom from the 1 year onwards till 80 years. A geriatric patient may come with osteoporosis, multiple fractures because of vitamin D deficiency, malabsorption, and first time diagnosed as celiac disease on investigation. So there is a spectrum. The next slide shows there is a similarity in the anemia of pediatric population versus adult population, and you can see the almost similar degree of anemia, iron deficiency anemia, B12 or folate deficiency anemia. The point to remember is this: in these cases of celiac disease, on iron supplementation, the hemoglobin doesn't improve. So this is an important MCQ and lesson to be learned, that these are not responsive iron deficiency anemia. If you give them treatment, they will not respond. Coming to the biopsy of the pediatric and adult, almost the marked staging you can see the similar in both the children as well as adult population. The staging 2 and 3 are almost similar pattern. So we'll be in subsequent slides, we'll be discussing the duodenal biopsy and marked staging done on histopathology. This is the symptom difference in adult groups. The most common one are abdominal pains, vomiting, abdominal bloating, and diarrhea, and weight loss. Rare symptoms are abdominal distension, pedal edema because of hypoalbuminemia, dysphagia, and malignancy. These are rare symptoms. Coming to the children, again the growth chart. The parents may approach you that sir मेरा बच्चा बढ़ नहीं रहा है और क्लास के बच्चे तो बढ़ रहे हैं, मेरा क्लास का बच्चा बढ़ ही नहीं रहा, मेरे बेटे की हाइट ही नहीं बढ़ रही है. So growth charts are very important in such children. Every pediatrician should make note if the child is growing below third centile, he is a high risk child to be investigated for celiac disease. The growth sensitive enteropathic growth can demonstrate initial normal growth from 0 to 9 months, followed by onset of poor appetite with intermittent vomiting and diarrhea after initiation of gluten containing diet, single arrow, after biopsy, confirmed diagnosis and treatment with gluten free diet. The double arrow growth shows the growth improvement. Coming to the indication of prompt testing, the National Institute of Health Care and Excellence guidelines on the indications that should prompt testing for celiac disease are: the celiac testing and recommended is persistent unexplained abdominal or GI symptoms, faltering growth, prolonged fatigue, unexplained weight loss, severe and persistent mouth ulcers, unexplained iron, B12 and folate deficiency, type 1 diabetes children, autoimmune thyroid diseases, irritable bowel syndrome, first degree relatives of people with celiac disease, dermatitis herpetiformis, and the celiac testing should be considered in a child with metabolic or adult with metabolic disorder, reduced bone mineral density, or osteomalacia, unexplained neurological symptoms, particularly peripheral neuropathy and ataxia, unexplained subfertility or recurrent miscarriages, the persistent increased concentration of liver enzymes with unknown cause, dental animal defects, Down syndrome, Turner syndrome, and Neal syndrome, and selective IgA deficiency should be screened for celiac disease. The coming to the extra-intestinal manifestations of already mentioned, the it could be cutaneous, endocrine, hematological, hepatic, muscular, neurological, and skeletal, and others. And among the cutaneous, the hematological manifestation, the iron deficiency anemia, which is resistant to oral iron therapy, is the most common presentation in children with celiac disease, followed by a short stature. The condition other than celiac disease that can cause duodenal lymphocytosis or villus atrophy. In subsequent slides, we will discuss how the duodenal biopsy histopathology revealed the lymphohistiocytosis, that is more than 30 lymphocytes in a lamina propria, and the DDA for that may be other than the celiac disease. The condition which can cause duodenal lymphocytosis are food allergen, non-celiac gluten sensitivity, infection with H. pylori and giardiasis, drugs with NSAIDs, post-enteritis syndrome, immune deficiency, selective IgA deficiency, common variable immunodeficiency, immune dysregulation with autoimmune thyroiditis, Crohn's disease, pre-infiltrated intestinal T lymphoma. The patient who shows villus atrophy and do not have celiac disease can maybe mimic environmental enteropathy, common variable immunodeficiency, autoimmune enteropathy, drugs like olmesartan, azathioprine, food allergies, giardiasis, Crohn's disease patient, eosinophilic enteritis, radiation enteritis, intestinal lymphoma, HIV enteropathy, bacterial overgrowth, graft-versus host disease, and protein energy malnutrition. So same person can show the total villus atrophy. And once the recovery occurs in these children, the villus will grow and they become normal. They start gaining weight and height. So this villus atrophy in our Indian children, the same should be very differential diagnosis. Coming to the serological testing, the anti-gliadin antibody, anti-deamidated glycate peptide, endomysial antibody, anti-tissue transcriminase antibody. In our days of post-graduation and residency, the test of IgA, TTG were not available and now is easily available, and all the pediatricians and adult physicians are sensitized for workup of this serology, and that they are getting a screening test for the IgA TTG. Coming to the serology in children, special considerations, IgA TTG antibody is the diagnostic tool of choice to detect celiac disease beyond toddlers. Anti-endomysial antibody has better specificity than IgA TTG but is costly. For children less than 2 years, IgA TTG plus diglutide peptide antibody should be analyzed. In case of IgA deficiency, the IgG TTG and IgG DGP should be used. So this is point to be remembered. In the children with IgA deficiency, the IgG TTG and IgG DGP should be used both. And in for children less than 2 years, you are suspecting the child is not growing well, getting anemic, and the child is just 1.5 years and ITTG levels are high, you must proceed for duodenal biopsy for confirmation of celiac disease. The IgA tends to be lower in younger children, reaches adult level at the 6 to 7 year of age. As per the Aspagan, high IgA TTG more than 10 times on 2 separate blood samples plus positive endomysial antibody is considered diagnostic if biopsy is not done. Seronegative celiac disease, clinician may face situation in which villus atrophy is present on duodenal biopsy, but serology is negative. This suggests presence of alternative diagnosis or seronegative celiac disease. The TTG antibody has been found in small bowels of seronegative celiac disease. They are unable to pass into the circulation. So seronegative celiac disease is a more severe celiac disease and diagnosis and required exclusion of alternate causes of villus atrophy, response to gluten-free diet and permissive HLA typing. Now coming to the HLA typing, the important point you must note and remember the HLA DQ and DQA, their absence means the disease is highly unlikely. They rule out the disease. Not useful for diagnosis. HLA typing has been recommended for screening measure of seronegative first degree relatives or individuals with celiac disease as well as mismatch between serological and histological findings. Regarding the duodenal biopsy, the duodenal biopsy, upper GI endoscopy with biopsy is a gold standard, but recent guidelines do not recommend as an essential guidelines if IGA-TT is more than 10 tests normal and EMA is positive, the duodenal biopsy may not be required. As per the ACG, the 4 from the second part of the duodenum, that is the descending part of the duodenum, and 2 from duodenal bulb should be taken, but recently the guidelines have mentioned even instead of 2, 1 duodenal bulb biopsy is enough. So total of 5 biopsy tissues are required to read by the pathologist to give you diagnosis of villus atrophy and lymphocytosis in the lamina propria infiltration. Coming to the Marsh staging of histopathology, this dear student, you must remember the Marsh staging of histopathology in the exam. The slide might be there, and you have to identify this which class of the Marsh staging of celiac disease the child is in. The system 0 is villus architecture is normal, crypts are normal, intraepithelial lymphocytes are normal. In class 1, the infiltrative, and class 2 is hyperplastic. The class 2, you can see the enlarged crypts in increased division in crypts. Intraepithelial lymphocytes are increased. And class 3A is the crypts are increased, intraepithelial lymphocytes are increased, but now the villi start short and blunted. Star 2B is the atrophic villi, crypts are enlarged, increased immature epithelial cells and intraepithelial lymphocytes are more than 30 and increased tremendously. The class 3C is the total atrophy of complete loss of villi, severe hyperplasia of crypts, intraepithelial lymphocytes are increased markedly, they are more than 13 lamina propria in every field. So this is, you can see in this slide the stage 0 and 1, you can see the beautiful, the villi are there, the finger-like projections. And as the disease progresses from 2 to 3, you can see the regressions in the villus size. 3B is regress and 3C is the totally villus atrophy. So these slides you must be very familiar with it. It may come in need to super specially as a slide to identify which stage of the Marsh staging the celiac disease is there. Coming to the diagnostic algorithm of the celiac disease, this is mentioned in our Nansen textbook of pediatrics 22nd edition, and this algorithm has been taken from the Journal of Pediatric Gastroenterology 2020, page number 1341 to 14157, figure 4. So diagnostic algorithm of celiac according to European Society of Pediatric Gastroenterology, Hepatology and Nutrition, Espegan. Celiac disease, you can see when you are working up the child with adverse symptoms, anti-IgA and get a total IgA, and if anti-IgG is positive and more than 10 times of the normal is positive, get the endomysial antibody done. If endomysial is positive, the child is diagnosed with celiac disease. You have to counsel the child and the family for gluten-free diet and frequent follow-up. If the titers are less than 10 and EMA is negative, get the biopsy done and see in which stage the child is. If it is Marsh 2 or 3, it is celiac disease. Again, it's a confirmed diagnosis of celiac disease. Put the child on gluten-free diet and follow up. These are the current recommendation of aspirant 2022-24 guidelines. They are the 10 rules which are the current, as you mentioned on the previous slide, the biopsy is not mandatory. If IGTT is more than 10 times normal and EMA is positive, the child is confirmed case of celiac disease. But if the titers are below less than 10 and EMA is negative, then you have to need the biopsy necessity. Cerebral testing is mandatory in every child. HLA testing is to screen the first degree relatives of the children, and its negativity rules out the celiac disease. Initial follow-up to be done 6 months, 3 months to 6 months, then 6 months to 1 year, then 1 to 2 years, and then of 2 years biannually, and according to the child or adult population behavior, you can do the follow-up. The biopsy monitoring is really required in this diagnosed case of celiac disease or something alternative diagnosis you have in your mind. The diagnosis biopsy can be repeated. Dietary adherence is a lifelong, and the celiac passport is when the child is transforming to the adolescent to the adult age group. Diet has to be celiac disease rest of the life till the 80 years plus. So this is the celiac passport. The diet habits will remain the same. The gluten cross contact. What is gluten cross contact? सपोज लेंगे हमारे हिंदुस्तान में लोग चक्की पे आटा पिसवाते हैं, अब उसी उसमें वो चावल भी पिसवाते हैं, दाल भी पिसवाते हैं, सोयाबीन भी पिसवाते हैं कि भाई बच्चे को तो हम ग्लूटेन फ्री डाइट देंगे, चक्की पे आटा पिसवा के देंगे। मगर हुआ क्या, उसी चक्की में आटा भी पिस रहा था, gluten came in contact, and unintentional intake of more than 25 milligram of product is hazardous. सो आपको काउंसिल करना है पेरेंट्स को कि भाई आपको ये जो है ग्लूटेन फ्री चाहिए, आप अपने घर में खुद पीसिए लेग्यूम्स को, सीरियल्स को, डोसा इडली जो भी आपको बनाना है, तो ये आपको घर पे बनाना है और इसमें किसी तरह की कंटेमिनेशन नहीं होनी चाहिए. दिस इज कॉल्ड ग्लूटेन क्रॉस कॉन्टैक्ट. Coming to the nutritional considerations of gluten-free diet, as I've already mentioned, gluten-free food is food that is inherently gluten-free or has been processed to remove gluten to less than 20 parts per million or 20 milligram per kg of the product, including ingredients and cross contacts. Cross contact occurs when a gluten-free food is exposed to gluten-containing food, thus making it unsafe for a person with celiac disease, as occurred in restaurant workplace. डॉक्टर साहब मैं तो बच्चे को घर पे खिला रही थी, फिर भी कैसे इसको सिम्टम्स रिकर हो गए, फिर से खून की कमी कैसे हो गई, फिर से बच्चा छोटा कैसे होने लगा? वो इसलिए होने लगा कि वो ग्लूटेन कांटेक्ट में आ रहा है, और आप टीटीजी टाइटर कराएंगे उसको पता चलेगा वो फॉल ही नहीं कर रहे हैं, रादर वो इंक्रीज लेवल पे स्टैटिक हैं. तो यू मस्ट सस्पेक्ट देयर इज सम ग्लूटेन कांटेक्ट. And in further slides, we will also discuss if the gluten celiac disease diagnosed patients, whether pediatric or adult, if accidentally come in contact with gluten, what adverse reactions can happen, how to handle them. Common nutrient deficiencies in celiac anemia, as I have discussed, this is a MCQ iron treatment given the iron resistant anemia is the hallmark feature of celiac disease, followed by B12 and folic acid, vitamin D deficiency, zinc deficiency, and vitamin B6 deficiency. The initial dietary therapy principles are avoid all foods containing wheat, rye and barley. Gluten pure oats are usually safe. Avoid malt unless clearly labeled or derived from corn. Only use rice, corn, maize, buckwheat, millets, amarnath, quinoa, sorghum, potato starch, soybean, tobacco and teeth bean and nut flours. Make sure whatever the diets you advise, it should be economically favorable to the community, to the family. It should not be expensive diet. Wheat starch and products containing wheat starch should be only if they contain less than 20 parts per million of gluten are marked as gluten free. Read all label and study ingredients of processed foods. Be aware of gluten's in medications, supplement, food additives, emulsifier, or stabilizers. Limit milk and milk products initially if there is evidence of lactose intolerance. Avoid all beers, lagers, and ales and stouts unless labeled gluten free. Wine, most liquids, ciders, and spirits, including whiskey and brandy, are allowed in the adult age group for social drinking. Some potential source of hidden glutens are beers, ales, other fermented beverages, bouillons and soups, candies, commune wafers, drink mixers, gravy and sauces, herbal tea, imitation meat and seafoods, nutritional supplement, play-doh, salad dressings and marinades, सेल्फ बास्टिंग टर्कीज एंड सोया सॉस. ये बाजार में जो सोया चॉप मिलती है ना, उसमें 90% मैदा होता है. मैदा, सोयाबीन तो होता ही नहीं. इट्स वेरी एक्सपेंसिव. सो प्लीज abstain from this soya chops available in the market. Follow-up celiac disease. The NICE guidelines recommend yearly review of celiac disease patients for measuring weight and height, review of symptoms, considering need for assessment of diet and adjustment to gluten-free diet, considering need for specialist diet. Follow-up should be based on symptom and signs and not for screening of malabsorption parameters. In children, satisfactory increase in weight and height is essential marker of success of gluten-free diet. Follow-up biopsy is only done when remissions are not achieved, or there is a resistant celiac disease, which we will discuss in further slides. In follow-up of adults, baseline DEXA scan should be done, vitamin mineral supplementation to be done, long-term improvement in bone density and bone microstructure is targeted. Vaccination given against pneumococcal, hemophilus, meningococcus are recommended. Decreasing IDA TTG is a sign of effective gluten-free diet. Normal titers are insensitive for ongoing gluten exposure of enteropathy. Intestinal biopsy should be mandatory in patients with persisting symptoms despite consistent of evidence of gluten-free diet. What is refractory celiac disease? The child or adult is on the gluten-free diet for more than 1 year and still is not showing any improvement in the symptoms and the markers and the biopsy, so you must suspect is a case of refractory celiac disease. The general incidence in the population among the children or adults with celiac disease is 0.24% cases of refractory celiac disease. The two clinical categories are patients who have no initial response to gluten-free diet, patient who experience initial clinical improvement on gluten-free but after a period of remission develop disease refractory to glutamate abstinence. The type 1 least severe presentation, much better prognosis, does not evolve into type 2. The 5-year survival of type 1 is 96% versus 58% of type 2. Type 2 may be associated with severe malabsorption, death in 55% of untreated cases. A small subset patient develops subepithelial collagen deposit, collagen sprue. Coming to the refractive celiac algorithm, which is again mentioned in the textbook of pediatric Nelson, 22nd edition, and is taken by Nelson from the Gastroenterology 2022 protocol. And you can see in this algorithm the diagnosis for patient with non-responsive celiac disease. Non-responsive celiac disease can be defined as persistent symptoms and signs, develop 6 to 12 months of dietary gluten avoidance. And abnormal tissue transglutaminase can be even for 2 to 3 years. The positive serological testing for celiac disease despite 12 months of treatment with a gluten-free diet suggests there may be ongoing gluten ingestion refractory celiac disease defined as a persistent or recurrent malabsorption. And the abnormal intestinal lymphocytes may be identified by immunochemistry of epithelial lymphocytes or of flow cytometry showing an increased number of CD3 positive cells and lacking CD8 and identification of clonal T receptor gene rearrangement. Regarding the HLA leukocyte, this is the brief protocol. If non-responsive, she confirm accuracy of celiac diagnosis. Yes, serological serologies, expert dietitian opinion, clinician, gluten ingestion, and other intolerance identified. If it is no, then small biopsy with colony biopsy if persistent diarrhea. So here sometimes you have to take even a colonic biopsy along with a duodenal biopsy. The enteritis with villus atrophy, if yes, reconsider exclude other mimics of villus atrophy which we have discussed previously. Refractory celiac disease usually occur in adults. The percent prevalence in population is 0.5 to 4% only. Abnormal or colonial intestinal T lymphocyte, if it is yes, it's a marker of type 2 refractory disease which has a high mortality. And if the clonal T lymphocytes are absent, it's marker of type 1 refractory celiac disease. The future treated options are larazotide, that's 8 amino acid capsules. It acts as a gut barrier stabilizer or tight junction regulator, maintain intestinal barrier function and gluten challenge, and favorable effect on intestinal permeability and gluten ingestion. More useful in patient inadherent gluten ingestion. The transglutamin inhibitors under research are competitive amine inhibitors, reversible inhibitors, irreversible inhibitors, and HADQ blockers. These are the field of the research and for the coming. The treatment of acute reaction to gluten, this is very important. A child diagnosed or adult diagnosed with gluten get an exposure of gluten diet and he shows severe skin and vomiting and pain abdomen and urticarial reaction. How to manage them? This is very important. This part is not covered in your Nelson Book of Pediatrics. There are various protocols in which the budesonide given in the encapsulated form, the dose may be in 3 to 6 milligram divided dosage to the maximum of 9 milligram. The duration may vary from 1 week, few days to 1 week to 4 weeks in different protocols, and the response is very good. And again, you have to avoid the gluten-free diet so that in near future, such kind of adverse reactions do not occur in child celiac disease. So, capsule budesonide available in the market, say 3 milligram, 6 milligram, 9 milligram, encapsulated. This part must be very important for you regarding the theory exam and NEET super specialty exam. Some patients in near future may show ulcerative jejunitis and intestinal lymphoma. Both have similar pathogenesis and aberrant T cell monoclonality. Ulcerative jejunitis may lead to stricture and poor response to gluten-free diet, 33% mortality. Prognosis improved, dissection and osmosis done timely. Here comes the role of surgical gastroenterologist. Non-celiac gluten sensitivity, a word about it, the clinical entity induced by ingestion of gluten leading to intestinal and extraintestinal symptoms that resolve once gluten-containing foodstuff is eliminated from the diet when celiac disease or wheat allergy has been ruled out. It is an example of food sensitivity. Coming to the clinical feature of non-celiac gluten sensitivity are clinical similar to irritable bowel syndrome. Extra-intestinal manifestations are more prevalent in non-celiac gluten sensitivity. Symptoms occur soon after ingestion or dissipates after withdrawal of ending foods. Patient would be treated for CD serology, tested for celiac disease serology and wheat allergy with IG levels. Bloating and pain abdomen 80% of patients, diarrhea in 50% of children and adults, jar, nausea, vomiting and epithelial dermatitis, low levels of vitamin D3 and folic acid and iron are found on blood investigations. High prevalence of autoimmune markers are in such cases of non-celiac gluten sensitivity. So this is the chart difference between irritable bowel syndrome, non-celiac gluten sensitivity and celiac disease. The celiac disease we have already learned what all can happen, the outcome in the complication of the refractive celiac disease. You can see the lymphoma may occur, small bowel adenocarcinoma may occur, and ulcerative jejunitis, which you already discussed. Coming to the irritable bowel syndrome, this is the most common differential diagnosis of prolonged diarrhea, vomiting, pain abdomen, passage of stools 8 to 10 times per day, is a chronic in duration, multifactorial, the onset of age usually 40 to 50 years. Females are much more common in females than males. Familiarity of gluten disorder is variable. Symptoms are gastrointestinal, biomarker HLA and duodenal histology are normal in irritable bowel syndrome. Autoimmune disorders are low prevalence and the reduced bone density are normal. Food intolerance, usually they have a lactose intolerance associated. So if you make them lactose-free diet, the symptoms may improve. Outcome, no complication, DPCC, unnecessary for diagnosis. So I acknowledge and thank to my son, Dr. Devesh Kumar Bhagwani, Dr. Payal Mittal, and Dr. Sahib Singh for helping me in the preparation of the slides and the review of the literature of celiac disease. I hope you must have enjoyed the talk. You must subscribe this video on YouTube, share it with your colleagues and friends and juniors and seniors, and comment if any doubts with you. And I thank you all for kind listening and warm regards and Jai Shri Ram.